All right, we're going to get started. We are recording it, so if people do miss, they can always go log on to our website after this and review the recorded webinar. But thanks for joining. Today's webinar is Sweeping COVID-19 Changes in Regulatory Waivers Announced. And we really appreciate you taking some time out of your busy schedules. We know everybody's really busy during these times. But before we start, I'm just going to cover a few housekeeping items. All attendees are on mute, just to eliminate background noise, but we do encourage you to interact with us and our speaker, and you can do this through the Q&A panel on your interface there in Zoom. And we will answer your questions at the end of the presentation as we have time, but if we don't get to all of them, we will create an FAQ doc after the webinar, and within a few days, we'll post that to the webinar page as well. And so today's presentation is presented by Jennifer Bishop, Vice President of Product Content here at Vitalware. And so I'm going to hand it off to Jennifer and let her take it away.
All right, thanks so much, Dusty. I am hoping you can hear me. You're my Dusty, can you hear me?
Yeah, I can hear you.
Oh, awesome. I just wanted to make sure he's my test there to make sure that I've got everything set up okay. All right, folks, so let's get started. My standard disclaimer is here, particularly with this COVID stuff. This stuff can be outdated very quickly. If it is, we will make sure to update you about that and do another webinar if we need to. All right, so let me just start with, I need everybody to stick with me on this. This is some incredibly complicated stuff that we've got here. And the reason for that is CMS heard you guys, heard particularly facilities that they weren't able to bill, say, telehealth services to recoup their costs. And so I think rightfully so, they made some changes to that, but they have to work within the constraints of the laws that have already been enacted by Congress. So one of those laws, and I think we'll probably all agree it's a good law, is that hospitals can't charge for services that aren't provided at the hospital. And of course, that can be broader than that. But that's a good law, right? I mean, that means that if I go to my county fair and get a health screening that happens to be sponsored by the hospital can't charge me for that unless, you know, there's some special circumstances and stuff. So because of that constraint, as far as where services can be provided, we had to do some gymnastics in order to be able to bill for our telehealth services. So let me just start with that, and that's the reason that this is all so complicated. So I'm going to start right here with what is really important to our facilities, which is there is now a relocation of provider-based departments. So they are allowing temporary extraordinary circumstances to be in effect from March 1st until whenever the end of this public health emergency is declared. So I don't have an end date for you right now, but it is retroactive back to March 1st. So this is where I'm going to need you to stick with me here. So if you have an on-campus provider-based department, which I'm sure pretty much everyone does, or you have an accepted off-campus provider-based department, you are going to be allowed to seek an exception to relocate your provider-based department for the purposes of addressing this public health emergency. That relocation is going to allow you to be paid at the OPPS rate, and we're going to assign the PO modifier to that to tell CMS that you're providing the services at an off-campus provider-based department that has been accepted under this new rule. So some of the rules to that is this relocation has to be consistent with your state's emergency preparedness or pandemic plan. In other words, you can't just relocate because you feel like it. This relocation means that you can relocate your provider-based department to the patient's home. So essentially, the patient's home now becomes an arm of the hospital, a department of the hospital. So we're already a little complicated there, right? Now all of a sudden you've made your patients' homes provider-based departments. So that's step one to this thing. You can provide services at the new location before you receive approval to do this relocation. So you can start providing these services at your off-campus provider-based departments, which again can be your patients' homes, as long as you're in compliance with, you can't just do it because you want to. There has to be a reason that you're doing that. Okay. So you also have to seek approval for this through your CMS regional office, and I'm going to go into that more a little bit later. So here's a couple of catches. You can provide these services right now with your PO modifier, and you're going to be paid at your OPPS rate, and I'm going to go into a little bit more what services you can do that with. However, if you start providing services today and you do not get approval from your CMS regional office, you're going to have to rebill all of your claims using the PN modifier, which basically means you're going to be paid for all of your services under the physician fee schedule rate, which is equal to 40% of the OPPS rate rather than being paid at your OPPS rate. The other thing that CMS said is following the end of this public health emergency, they do expect these provider-based departments to relocate back to the original location. Should you choose not to relocate back to your original location, and of course this would apply more to actual relocation of your provider-based departments. In that case, if you decide to keep that provider-based department at another location, it is at that point going to be considered to be a non-accepted off-campus location, which means all of your services going forward will be paid at the physician fee schedule rate, or equal to 40% of the OPPS rate. So I realize this is really complicated, but remember again that CMS didn't have the authority to say that the hospital could just provide services at patients' homes or at a remote location without going through some of these gymnastics because of the law that was already written. Okay, so let's say you are a provider that would like to do this, that would like to apply to the CMS regional office to relocate your provider-based department temporarily off-site. How do you do that? You need to send an email to your CMS regional office, so that's different depending on, for everybody, depending on what part of the country you're in. You have 120 days after the start of these remote services to send that email. And here's the information that you have to give them. The hospital CCN, the address of the current provider-based department, the address or addresses of the relocated provider-based department, the date when you started furnishing services, and a brief justification of why you need to do that, and an attestation that that relocation is consistent with your state's emergency preparedness or pandemic plans. Okay. And I can hear it now already, and this is, I know I'm going to get questions, and I'm not sure I can completely answer them right now, which is regarding these addresses. So if you send all of this to your regional office today, you're not going to have every single address of the patients that you're going to be seeing in the next week or the next month or however long this goes. So we're going to have to get a little bit more guidance as to how you update those addresses, because CMS did say that you only have to send this email once. Requesting temporary relocation. All right, so let's talk about the specific services you can and how we're going to do this. So CMS said that hospital outpatient therapy, education, and training services may be provided by clinical staff of the hospital using these telecommunications technology in the temporary expansion locations, and that includes the patient's home. So you can now, your staff of the hospital can now provide these services via telehealth because they are basically providing them in the hospital, in a relocated provider-based department of the hospital, even if the patient is at home. Okay, so this is where we can bill these services, and if you get approved by your CMS regional office, you can use a PO modifier, and these services are going to be paid the same as if you were doing them in the hospital. Okay, the supervision levels still apply. Most are general supervision, and that supervision component can still be met via audiovisual component. Okay. The services are still going to require an order from a physician or a non-physician practitioner, and that, of course, who can order that is not changing. That still needs to be done in accordance with the hospital privileges you've afforded to them, the state licensing requirements, and their own scope of practice. Okay. And as I said, you're going to bill for those services as though they were provided in the hospital, adding that PO modifier, because essentially they're being provided in an off-campus provider-based department. Okay, so CMS nicely published a list for us of those, what they would expect those services to be. And they did note that this is not a comprehensive list. They're going to be updating this periodically. These are examples of services they would expect to be furnished via telehealth by that clinical staff of the hospital. So I didn't have enough room to put all these codes out there for you, but I did break them down into categories and list the codes that CMS has listed. So you can see it's stuff like diabetic management, remote physiologic monitoring, lots of therapies, nutrition therapy, physical therapy, that kind of stuff. All right, they also said that partial hospitalization program services, or PHP services, can be provided by facility staff of a hospital or a community mental health center using the telecommunications technology, same verbiage there, in the temporary expansion location that is functioning as a provider-based department of the hospital. And they gave out some different services there that they would expect could be provided this way. So it's basically psychotherapy and education. All of this has to include audio and video, although there is an exception to if you just can't get the, the video. There is an exception to that, but you also have to make sure that that's appropriate, right? If you're going to be doing audio only because, let's say you've got an older patient and they just don't have access to the internet, you can provide these audio only, but you have to make sure that that is medically appropriate, that you can actually provide the service that way. Okay. No other changes to the rest of our partial hospitalization requirements. And again, CMS gave us a nice little list there of what services they would expect to be provided via this telehealth service. Telehealth, yet not telehealth, so. Okay, another area here, hospital in-person clinical staff services can be provided by the facility of staff of the hospital in these temporary expansion locations that are, again, functioning as an off-campus provider-based department of the hospital, with some caveats there. And basically that, you know, this is where your clinical staff goes to the patient's house to provide things like maybe wound care, maybe they're going to do an infusion, something like that. And we're going to bill for those as though they were done in the hospital, because technically they are being done in the hospital, just in a temporary relocated site. Okay, so it's important though to note if the patient is already under a home health plan of care and the services can appropriately be provided under that home health plan of care, the hospital staff shouldn't be doing that. They should allow the home health nurses to do that under the home health plan of care. So we don't want to overlap these things. So be careful before doing this and billing for this that the patient isn't already under some sort of home health plan of care. And hospitals, excuse me, this is slightly different, but we're still on the same sort of topic here. So this was maybe the biggest thing that we were being asked about is how do I bill that originating site telehealth fee when the patient is at home and the doctor is sitting in my hospital? That doesn't qualify ordinarily for the Q3014 because the patient has to be sitting in your hospital in order to bill that Q3014. And what happened is, of course, hospitals still have a cost associated with that telehealth because the physician's using your equipment and it's your medical record, all of that kind of stuff. So the hospitals weren't able to recoup any of that costs. So again, because we couldn't make certain changes to the law this quickly and on the fly, what they've done is, say it with me now, this would be a good category for the drinking game here, maybe. We are providing the services in a temporarily located off-campus provider-based department. So now, even though the patient is sitting at home, they are sitting in an off-campus provider-based department of the hospital, and hospitals can bill that originating site fee with that Q3014. So this follows the same logic as what we were just looking at there. So if the hospital has sought an exemption or will be seeking an exemption under this relocation policy, we're going to bill the HCPCS code Q3014 with modifier PO, and this is what the payment is for this calendar year. If the hospital does not plan to seek an exemption under this relocation policy, you can still bill the Q3014. You're just going to report it with the modifier PN, and you're going to be paid at that Medicare physician fee schedule rate of $10.66. So it's just 40% of the full OPPS payment rate here, is how that rate is arrived at. So hopefully I don't have everyone in knots there. I know there's going to be questions about that at the end because, yeah, it's something, but CMS listened to us and understood that we couldn't provide these services for free, and so this is what we've got to make that happen. Overall, it's positive. It's just a little bit of paperwork to get there, right? All right, so now let's talk about probably the second biggest thing I've heard about, which is some of the diagnostic testing. CMS officially, in the interim final rule that they just released, is officially going to cover FDA authorized COVID-19 serology tests under the clinical diagnostic fee schedule. Now, they haven't released payment rates quite yet, unless they did it this morning, but they are going to be covered. And basically their point there was none of these tests went through the NCD process to establish medical necessity, but they did put in a criteria here that they only expect these to be billed once per sample. There shouldn't be any reason that you need to do 2 serology studies for a single sample there. Specimen collection. This is another big one because hospitals essentially had no good way to bill specimen collection when that was the only thing that they provided for the patients, maybe at drive-up clinics or strictly the patients just came in to get a COVID-19 test. So CMS has created a new HCPCS code, C9803, and you can see the description there. It is actually hospital outpatient clinic visit specimen collection for COVID-19. They've assigned that to APC 5731. It has a national reimbursement rate of $22.98, and it is a Q1, which means that it's going to be bundled when you do any other service, basically, when you do a clinic visit or when you do a procedure or anything other than the lab test. So you can bill specimen collection and the lab test, and both will be separately paid. But if you try and bill anything else, basically besides some lab tests, it's going to be bundled into that. All right, I also wanted to talk about specimen collection in the physician's office, and they gave a couple of different scenarios for that. So they said in the physician's office, if the specimen collection is the only thing we're doing, they recommend billing 99211. And you'll notice here, this is a pretty important exception here, that they're recommending that 99211 for new and established patients in the physician office. So even if you've never seen that patient before, and they come in just to get a COVID-19 test, you're still going to bill 99211 for that. And our second scenario is specimen collection being done just in addition to as part of the E&M service. And in that case, you're not going to separately bill the specimen collection because it's going to be included in the larger E&M service when it's done in the physician's office. All right, and the specimen collection from the homebound patient. So I just wanted to quickly address this. This isn't new. This was from the other interim final rule. And I just put it in here because we had a lot of hospitals trying to build this G2023 for their specimen collection. And that's not appropriate. That's not what that's for. That is for lab techs going out to homebound patients. Of course, now we have some exceptions as to what is homebound and what's not. But so I just put these out here just so that you would know that this is to be used by lab techs that are sent out to homebound patients. All right, that covers our lab. Now let's look at some of the scope of practice changes. So some of the things that are going to impact you there are the fact that nurse practitioners and clinical nurse specialists, physician's assistants, certified nurse midwives may order, furnish directly, and supervise the performance of the diagnostic tests in accordance with their own state law. So you can't go outside of state law, but now instead of having to have all this directly furnished and supervised directly by a physician, we're expanding who can actually do that. Okay, and that's going to include psychological and neuropsychological testing. Therapy assistants can now perform maintenance services, but that's going to be at the discretion of the physical therapist and the occupational therapist who actually established the maintenance program. So they can delegate when they feel it's clinically appropriate to delegate to a therapy assistant, and that stuff can now be billed. So. Okay, I should have put this one in red and flashing. Any healthcare professional who's eligible to bill Medicare for their professional services can furnish telehealth services. I know this is going to be another point of confusion to people because what this looks like and what it is actually is saying, oh, well, if physical therapists can now bill for telehealth services and my physical therapy services are on my telehealth approved list of services, why don't I just bill my physical therapists who are hospital staff? Why don't I just bill them as though it's telehealth? Well, this part of this is for our professional services. So what this is saying is if you have a physical therapist and they bill Medicare on a CMS 1500 form, they can now do that. They can bill for their therapy services on the 1500 form. Okay, so it's a little bit different than when we're talking about the facility billing. And I know that just makes these things just clear as mud, but there is a difference to all of the rules for facility billing and professional billing. So also, any individual who may furnish and bill for their professional services may review and verify the notes in the medical record rather than having to redocument everything. So this is primarily going to hit our therapists, right? Because before they couldn't take say what the physician had written in the medical record and just sign off on it that they had read it and reviewed it and agreed with it. They had to redocument all of the medical necessity, all of the history. They no longer have to do that. They can actually just sign and date verifying that they actually reviewed the healthcare provider's notes. All right, CMS also provided clarification. This is not new either, but apparently it was a point of confusion. So they just clarified that pharmacists could provide services that are incident to the services of a billing physician or a non-physician practitioner unless the payment is already made under the Medicare Part D benefit. So this was primarily to do with the medication management services. Pharmacists can furnish those services as long as it's incident to the services of a billing physician, and that can be billed by the billing physician. Okay, we have a little bit of a modification to ordering requirements in that lab tests for COVID-19, influenza, or RSV do not require an order during the current public health emergency. So what that means is if I'm a patient who has symptoms of COVID, I can actually just come and request a test. I don't have to have my physician actually write an order for that test. The test results are supposed to be reported out to the patient and to local health officials as required. So that would be, you know, if you obtained a positive test, that in a lot of cases that has to be reported to local public health departments. We don't have any regulation changes if in fact the provider does order the test. So you would still, if the provider orders the test, that still needs to be documented, that why the provider is ordering the test, and results have to be provided appropriately. So you might, you know, why did they include all of these? And they specifically said it's because influenza and RSV frequently mirror the symptoms of COVID. So it wouldn't be outside of scope for a patient that's got symptoms of COVID to also test them for influenza and RSV, just to make sure that it's not one of these other two. Right, so that's a temporary waiver. And here's a list of the tests that will not require the practitioner order during this current public health emergency. So I just split them up a little bit. You can't always split these two out because some of these codes overlap. But here's a list of the tests that CMS will allow to be performed without a specific order. Okay, and then we have some waivers that are going to reflect specific programs or providers or that sort of thing. So the opioid treatment programs, the periodic assessments can now be performed using audiovisual technology, and this has kind of the same what do you call it? We have an exception, the same exception that we saw in some of these other things, that it can be audio only if the patient doesn't have video technology, and only if you determine that this assessment can be adequately performed audio only. Okay, and there's the code that this is impacting. All right, we're going to talk about some of the other provisions. And apparently this was a source of great confusion as well. CMS specifically called out in the interim final rule that there were some entities and providers and different folks somehow thinking that CMS had waived all of the NCD and LCD requirements during this public health emergency. That's not true. They did not waive all of their NCD and LCD requirements. What they did waive was the requirement for a face-to-face or in-person visit if the policy contained that language. They are also temporarily not going to be enforcing the clinical indications for these particular services: respiratory home anticoagulation management, infusion pumps, and therapeutic continuous glucose monitors. So they are not waiving clinical indications for anything and everything, only for these particular services, because they feel that, that there are really good reasons that folks would be using these things right now due to the public health emergency that don't necessarily meet the exact clinical indications that have already been written in the policy. Okay, remote physiologic monitoring services. These can now be reported to Medicare for periods of time less than 16 days. So the reason for this 16 days is right now, all of the codes that I'm talking about are billable once per month, and you cannot bill them. If you look at the CPT guidelines, you can't bill them if less than 16 days of services were provided. CMS is waiving that requirement, that 16-day requirement, and they're now saying that you can report those codes for anything where services take place 2 days or more. So if it's only 1 day, you're not going to bill it, but if it's 2 or more, you can actually bill these. This waiver, however, only applies to patients that have suspected or confirmed COVID-19 infections. Okay? And that applies to these particular remote physiologic monitoring codes. Okay, another thing that was in there, this is not exactly new. This was done in the last interim final rule, but CMS provided some more clarification there. So basically in the interim final rule that was published on March 30th, CMS had published with that a list of typical times for each of these E&M service codes. And in a lot of cases, they didn't match the typical times that were found in the code description itself. And so CMS just basically took away that listing they had that was conflicting. Whoops, sorry about that. And they are now using the AMA code description typical times. So I just listed those out for you. They're also in your book if you take a look at the times for those codes. Okay, and then we have some specific exceptions, waivers for teaching hospitals, and basically this is all about your payments. So you don't have to be worried if you're a teaching facility. If you actually temporarily increase your bed size to deal with the COVID-19 public health emergency, you're not going to be penalized by having a lowering of your IME payments. Also, if you send residents to other hospitals to deal with the COVID-19 public health emergency, you're not going to be penalized on that. You can still claim those residents. And this again isn't terribly new stuff, but it was clarified. So basically the long and the short of this is they're holding you harmless from surges you might make or help you might give to other hospitals. Your average daily census numbers are also going to be held at the pre-COVID-19 values for the IRF, the rehab facilities, and the psychiatric facilities. So your teaching status adjustments will not decrease during this public health emergency. Rural health clinics are also sort of being held harmless here. So if you're a provider-based rural health clinic that's currently exempt from the national per visit payment limit, you're going to remain exempt no matter what happens to the number of beds associated with your provider. Again, they didn't want anybody penalized for trying to help with increased care sites for the public health emergency. Home health agencies. An allowed practitioner may certify, establish, and periodically review the plan of care and supervise the provision. So that is now going to include, sorry, that should be a capital A there, nurse practitioners, the certified nurses, the physician's assistants. And this is going to be a permanent change. This is the one thing within here that is a permanent change for home health agencies. Freestanding inpatient rehab facilities, again, we kind of have some hold harmless stuff. So basically, if you are a freestanding inpatient rehab facility and you're taking patients to help free up acute care beds at a facility, there's some things that are waived here. You don't have to provide the interdisciplinary approach to care. You don't have to provide all of the documentation requirements, and you're not going to be subject to all of the coverage criteria. For any of those patients that you're providing care, you're going to append modifier DS, and that's going to signal CMS that that is one of those patients. And this is also pretty important here. Note that you can only take advantage of this if you're in a state or a region that is in phase 1. Or that has not yet entered phase 1. So if you're in a state or region that is in phase 2 or phase 3, as outlined in the guidelines for opening up America again, you can't take advantage of this basically. You shouldn't be accepting patients that are not meeting all of the criteria for the inpatient rehab. Okay. All right, long-term care. Long-term care facilities, there's some new reporting requirements. So long-term care facilities are going to need to electronically report COVID-19 information in a standard format at least once a week to the CDC. And that's going to have to be suspected and confirmed COVID-19 infections, and that is among the staff or among the residents. Okay, and it will include previously treated residents. You also need to report to them total deaths and COVID-19 deaths. You know, some of this isn't new. You had to report deaths to begin with, but you also need to report to them how much personal protective equipment and hand hygiene supplies you have on hand. You have to report the census. And, whoops, typo there. You have to also report to them what your access to COVID-19 testing looks like and any staffing shortages that you have for that week. There's also a new reporting requirement that the long-term care facilities need to inform their residents and their families and the representatives of any confirmed or suspected COVID-19 infections among the residents or the staff. Those updates need to be provided by 5 p.m. On the next day following a new confirmed infection, or if you have 3+ cases with new onset of respiratory symptoms within 72 hours of each other. And that is, again, among residents or staff. You also have to give weekly cumulative updates by 5 p.m. They shouldn't include personally identifiable information, so you don't tell everybody, oh, yeah, Susie down the hall and John have COVID. But you do have to tell them that there are 2 new confirmed COVID infections. Okay, it should include information on what mitigating actions your facility has implemented to try and stop the spread of the disease. And it doesn't require personal phone calls. You don't have to call every single family member in the residence. It can be paper notifications. You can post it out on your website. You can post a recorded telephone message on your outgoing phone. Oh, look at that. That is it. And now, as always, we'll make sure that you get this PowerPoint, and it will have the residents there. I'm sorry, the references. Been doing too much with teaching facilities.
Perfect. That's great, Jen. Appreciate it. A lot of good info, especially with just this being announced, a lot of this just last week. So appreciate that. We do have a number of questions in the Q&A panel. Just a reminder to everybody, please use the Q&A panel, not the chat panel, when submitting questions to make sure we stay organized on this stuff. And like Jen said, we will make sure to upload the presentation and the recorded webinar to the webinar page, and we'll send you an email with instructions on how to get those. And if we don't get to your question, we're just going to give you Jen's cell phone number, and you can text her, and we'll go from there.
Thank you, Dusty.
Kidding, of course. Okay, great. I'll start reading some questions here, and Jen will do her best to provide an answer. So the first question is, for provider-based departments that are performing telehealth services, are we required to change the modifiers from PO to PN? They have both facility types.
Okay, yeah, that's a good point. So if you're providing services in a non-accepted provider-based department, so you were always billing the PN modifier, you're going to continue to bill that PN. So you can't temporarily relocate to the patient's home and all of a sudden make that accepted if you weren't accepted to begin with. If you are one of those accepted provider-based departments, then in that case, you are going to continue. So basically, not much will change for you. You're going to bill with the PO if you're accepted. You're going to bill with the PN if you were non-accepted.
Great. Next one. Can you discuss the new code released for specimen collection C9803? Who can bill this and when? And can hospital labs bill this when lab personnel are collecting specimens and then performing the test?
Yeah, let's go back to that. So that is going to be billed by the hospital outpatient department, and it can be billed in addition to the lab test. So where I would envision this mostly being used would be if let's say your hospital has set up a temporary location for just doing COVID tests. The patient's maybe been referred by their doctor, maybe they're self-referring if you have enough testing supplies and that sort of thing. That would be where I would most expect this to be used, is the patients come in, they're coming into the hospital outpatient clinic, and remember that's broader. That could be a drive-up facility, for example. In that case, you would build a C9803. You'd send the specimen either to your lab, in which case you'd build a test, or you're sending it out to another lab, in which case you probably still build a test. It's just a little bit different setup. And this is where this gets a little bit sticky, is if your hospital staff is sending out a lab tech to a patient's home, remember again, that can be now a hospital outpatient clinic, the patient's home. So if you're sending out your hospital staff, and I don't know how necessary this is, you guys would have to tell me whether this is ever actually going to happen or not. Then you could still build this C9803. So these next two, let's go one more slide there. These other two codes are for if a lab tech, say in a freestanding lab facility, is actually sending out their lab tech, then they would bill one of these codes, depending on whether it's a homebound patient or a patient in a nursing home or for a home health. Hopefully that's clear as mud.
Yeah, great. And just a reminder to everybody, we are doing another webinar tomorrow where we're going to spend most of the time doing live Q&A. And so attend that if you don't hear your answer today. And then we have some more webinars coming up this month on telehealth and different things. So please look for our future webinars if you don't get your answer here. But I'll go to the next question. This person must attend webinars before. We appreciate that, because you may get to it. And I know you don't often provide guidance on revenue codes, but should we use 780 for telehealth or 510 for clinic visit? Since the home is an extension of the clinic hospital, what would you recommend?
Yeah, I would recommend using, basically we're pretending at this point as though you're providing the service in your clinic. So I would use the 510 in that case. I don't know if you remember from our previous webinars and previous things that CMS has said, but if you've got a physician in your hospital and the patient is even at another part of your hospital, so they're doing the services via telehealth, but they're both at the hospital, CMS considers that to be a face-to-face visit. And this is kind of the same thing. Even though we're not technically in the same place, we are considering this to be a face-to-face visit because both locations are being considered a department of the hospital temporarily.
Great. A couple more here, and then we're probably going to be out of time here with a few more. But C9803, you stated can be billed by facility on UB form with U0003, and both will be reimbursed by CMS?
Yes, that's correct. CMS said that this is in addition to the lab test. So that Q1 indicator means that this is going to be bundled when it's billed with a V, which is clinic visit, or an S or a T. I'm forgetting one. But basically, if you do another significant procedure, you're going to get, the payment's going to be bundled. But if you do this just with lab tests, then you'll be paid for both.
Okay, we have a lot of questions around C9803. Next one is that the effective date, what's the effective date, and is it retroactive to any particular date for any specimens that have been collected?
Oh, darn it. I'm going to have to look at that one. Basically, everything in that new interim final rule that they put out has a retroactive date to March 1st, but I need to verify that on this one, whether they're going back that far on this. I think so, but don't absolutely hold me to it. I'll make sure that gets answered correctly in the FAQ document.
Great. Can pharmacists conduct both telehealth and telephone visits under the incident to guidelines?
Ooh, another good question. I am going to have to look at that because pharmacists cannot bill Medicare directly for their services, and therefore believe they are not. So the list of folks who can provide the telehealth services are limited to the people that can who are eligible to bill Medicare for their professional services. I do not believe that includes pharmacists. So the
Okay,
answer would be no, but again, I'll make sure and do more research on that when we answer it in the FAQs.
perfect. I think we'll do about 2 more here. Can you please provide information how to bill for therapies on the hospital side, EBO4, provided by clinical staff such as registered dietitians? We understand
And that's
modifier requirements, but need further guidance on CPT and Rev code.
okay, and that's kind of roundabout the way, the one that we just answered. Basically, if you're applying for this exception to temporarily relocate your provider-based department to the patient's home, that means that even though the patient is sitting at home, they are considered to be in a provider-based department, which means that that is essentially a face-to-face visit when the physical therapist is performing that service via telehealth. So you're going to report that as you would normally if the patient was in your clinic visit, but you're going to add that PO modifier to let Medicare know that that is an off-campus provider-based department. So you would still use your, let's just say it's physical therapy, you'd still use your 420 revenue code on your UB. You'll report your services with the PO modifier and whatever other appropriate modifier, say a GP, to indicate that that's being provided under a plan of care. And your reimbursement should not change so long as the CMS regional office approves your request to temporarily relocate. Clear as mud again?
So you kind of just answered this, but it is a question, so I'll just maybe roll off of that. Can relocation be defined? We have some patients still coming into our PB locations and others being seen via telehealth.
Yeah, basically those aren't going to be any different right now as long as you want to apply for relocation. So relocation means, I understand what you're saying, like you're relocating a part of your department and a part of it is staying right where it is. So in that case, you're not going to make any changes to the patients that come into your provider-based department. That still is what it is. You can temporarily relocate a portion of your provider-based department out to either another location. Let's just say you've relocated your provider-based department to a school temporarily in order to provide testing or something like that. In addition, you're also relocating it to patients' homes temporarily. You can still do that and maintain your original location. The difference, there isn't really going to be much of a difference in the billing. You're still going to report the PO modifier on all the services.
Great. All right, this will have to be the last one, but again, we do have a Q&A webinar tomorrow that you can register for and attend. Here's the last question. Does this mean the pharmacist can bill an E&M as incident to with a level higher than the current 99211 limitation?
No, that's not what that means, because the pharmacist still cannot provide evaluation and management services that have that characteristic. The 99211 is the exception, but that's being used for other things. So no, this isn't changing the fact that the pharmacist can't provide evaluation and management services.
Okay, that's going to have to be our last one, but we will upload the recorded webinar, the presentation, as well as the answered Q&A to the webinar page, and we'll send an email out with instructions on how to get there within the next few business days or so. But again, we have a webinar tomorrow as well, so Jen and our content team are going to be very busy trying to research and answer all these questions, which is great. But please bookmark our resources page to follow future webinars, and you can follow us on LinkedIn as well. And we often post when webinars are coming up there as well. But thanks again for attending, and we'll talk to you all soon.
Right.
Have a good day.
Thank you.